Hello everyone. Today we're going to start our Zoom meeting. Dr. Amna will lead the Zoom meeting. When you're ready, Dr. Amna, thank you. Go ahead.
Hello, assalamu alaikum everyone.
Alaikum assalam. Go ahead.
I guess Dr. Eiman.
Yes, hello, how are you everyone? Assalamu alaikum.
Alaikum assalam.
Me and Dr. Rayyan are going to present the topic of hospital care. Unfortunately, Dr. Rayyan is a little bit under the weather, and we have a very big topic. So we decided to divide it. If you can do it the next week, we'll do part of it now, and the next week, inshallah, we'll do that.
Sounds good. I hope she feels better.
Thank you very much.
Thank you.
Let me share my. Sorry. Let me know if you can see my screen.
Yes, we can see.
Okay. So today we're going to speak about hospital care. And as we all know, hospitalizations can be something that is inevitable in elderly. And it definitely has a huge impact on health and healthcare. However, hospitalization can also carry some problems or can cause illnesses in itself, especially in elderly population. So our topic today, we will be talking about several things, and the two things that we will be talking about now are the hazards of hospitalization and the never events. Dr. Rayyan, inshallah, next week we'll speak about the assessment and the assessing and management of hospitalized older patients and the modules of care for older hospitalized patients. And during today's session, we will talk about the hospital-associated disability, delirium, suboptimal pharmacology, and sleep disturbance and nutrition. And we'll also speak about the never events, which carries the injuries, catheter-associated UTIs, and pressure ulcers. So while the elderly population in the US is around 13%, 35% of hospitalized patients or patients who receives urgent care, acute care, are from the elderly. So there is a large use of hospital or acute admissions from the elderly population than the younger population. The main causes that elderly are hospitalized for are congestive heart disease, pneumonia, cardiac dysrhythmia, and acute coronary syndromes. One of the issues that, of course, now everyone is talking about, and it has been going on for a while, sadly, it's the disparities in the hospital care. Minority patients are less likely to be treated with high volume hospitals for services for which high volume is associated with better outcomes than the white population. Disparities are the largest and very notable in the cancer surgeries and cardiovascular procedures, and hospitals that in the bottom quintile on most qualities, they serve significantly higher percentage of minorities than the ones on the top quintile. So it's something that is very sad that it's happening now, but it's one of the realities. So when we look at at elderly who receive care compared to the younger population, as I said, 35% of care is or acute admissions are from elderly. Compared, if we compare them to that, there is 13% of elderly in the country. Compared to younger adults, seriously ill, more than 80-year-old patients receive fewer invasive procedures and they cost less. Their treatment is less costly. They use less resource-intensive hospital care. These differences do not reflect the differences in patient severity of illness or the preference of expanding care. Sorry. So a lot of times, whether patients or whether the families of the patients or the physicians, they think elderly. They think elderly don't want to have extensive procedures, or they don't want to go through life expanding care. However, this is not true. So irrespective of the patient's age, the best guide to assess and manage the patient is the clinical circumstances and the patient's preferences. Many elderly patients want cardiopulmonary resuscitation, for instance. And while, for instance, I work in a nursing home setting, and it's always a question whether a patient why do they want cardiopulmonary resuscitation, even though they're terminally ill or they're 90, some of them are 100 or something. However, this should be based on what the individual want, more than what their family wants and more than what the physician think. So as they said earlier, the most determining factor should be what the patient want and the clinical circumstances of their illness. So in elderly patient, we try to our goal should be not to hospitalize them, try to manage their illnesses and not to get to the point that they're hospitalized. However, once they are hospitalized, they are at higher risk of losing their independence and to be institutionalized, whether they go to nursing homes or the rehab centers or stay in the hospital for longer terms. Among hospitalized medical patients, the 70 years and older, approximately 1/3 are discharged with a disability. That was not present 2 weeks before the admission, a condition that we refer to as hospitalization-associated disability. So 1/3 of patients age 70 or more, they come to the hospital, they develop a disability that wasn't present 2 weeks before their admission. And that's a big problem, basically. So hospitalization accounts for 50% of new onset disability in frail older adults. So hospitalization in itself is a risk factor for disability in elderly population. So as I said, the goal should be to avoid hospitalization and manage their illnesses and not to get it to go to a level that they need to be hospitalized for. Clinicians, they play a crucial role in educating patients and families regarding the harmful effect of limited activities and the need to engage in function promoting activity to avoid functional decline. So during hospitalization itself, clinicians and the medical staff should be very keen in reminding and educating the patients and the families of the importance of basically moving, eating, all the things that promote their healing, so they would have fewer hospitalization days and they can be discharged, and not to have to avoid the functional decline. Sorry. So there is a way to see if a patient has a high risk of developing hospitalization-acquired disability. Some of the factors that we look at when you have a new patient coming in, you should account for their age to see if they're 70 years old or more. That puts them in a higher risk. You should check for the number of dependencies in their activities of daily living and instrumental activities of daily living, whether they need help with their feeding, whether they need help with their movement, with their toileting, and with each one, it accounts for higher risk for developing HAD. Mobility 2 weeks before the admission, if they have metastatic cancer or stroke, or they have severe cognitive impairment or hypoalbuminemia. So if you have a patient who is 70 years or older who comes in, one of the things that you should keep in mind is those risk factors, because if they do have it, that means they have a higher chance of developing HAD, and if they have that high, their chances are higher, you need to focus on preventing, basically. Higher risk source predict more severe disability, greater likelihood of nursing home placement, and worse survival. One of the main problems that hospitalized patients get is delirium. Actually, there is 3 main problems that elderly hospitalized patient get. It's delirium, polypharmacy, and malnutrition, and cognitive impairment, which is part of the delirium. So if you talk about delirium, delirium is one of the predictors of prolonged hospital stay. And as we said, we don't want prolonged hospital stay. It's very prevalent. 18 to 35% comes in with delirium, and it can happen, its incidence rate is 11 to 14%. So it's very, very common issue. Delirium is associated with death, fall, nursing home placement, and worsening cognitive function. We have different types of delirium or subtypes of delirium. We have the hyperactive, which everybody knows, and it's very easy to identify. We have the hypoactive and mixed. The hyperactive one, the patient presents with restlessness, agitation. The patient is hyper alert, and it's rarely misdiagnosed. However, the hypoactive delirium, it presents with decreased movement. They have a burst speech, reduced responsiveness, and this is very similar to depression. So most of the time it's misdiagnosed as depression or dementia. One of the main useful tools to screen for delirium is the confusion assessment method. The confusion assessment method is a criteria that it's one of the main things that is used, and it's quite useful. We have to have we have to have, it has 4 criteria, A, B, C, D. You have to have both A and B, and one of C, either C or D. Concept or fluctuating course. You ask if there is any evidence of an acute change in mental status from the patient's baseline. Does the abnormal behavior come and go, fluctuate during the day, or increase or decrease in severity? The second thing is inattention. You have to have acute onset and inattention. For inattention, you ask, does the patient have difficulty focusing attention, become easily distracted, or have difficulty keeping track of what you say? Then you can have one of the two, either disorganized thinking or altered level of consciousness. With disorganized thinking, the way to detect it is you ask if the patient is thinking, if the patient's thinking is disorganized or incoherent. For example, does the patient have rambling speech, irrelevant conversations, and predictable switching of subjects? or unclear or illogical flow of ideas. Altered level of consciousness, overall, what is the patient's level of consciousness? You want to check if the patient is alert, vigilant or hyper alert, lethargic, stubborn or comatose. And having the first two and at least one of the second two is how you identify delirium. The incidence of delirium can be reduced by third if we manage the cognitive impairment, sleep deprivation, and immobility. To prevent or reduce the incidence of delirium, you should avoid medicines that are associated with delirium, prevent and treat any infection, and with elderly, you want to have a lower threshold for treating infections. For instance, if you have UTI, normally you treat UTI, it's more than, if the culture had more than 100,000, let's say, right? But with the elderly patient, you want to have a lower threshold. So if they have between 20,000 to 50,000, you want to treat it. From 50,000 to 100,000, you want to treat it. Detect and correct any metabolic abnormalities, which is very common with the elderly population as well, because they are easily dehydrated and they can have metabolic abnormalities. You treat their pain, you detect and correct urinary retention and fecal impaction. Fecal impaction is a very, very big thing. So you want to start patients who are hospitalized on bowel regimen as quickly as you can. Frequently orient patient and with cognitive and sensory impairment. This is a big helpful way that can be overlooked easily. It's very easy to basically lose awareness of time and days when you're hospitalized due to, like, the hospital is always, they have light all the time, their sleeping pattern is disturbed. So having as simple as a sign that says the date every day and frequently tell them what time is it, or this is the day, this is the morning, this is the afternoon, it can be quite helpful. You also want to avoid excessive bed rest, room changing, restraints, and unnecessary tethering. Promote nighttime sleep with non-pharmacological means. So this is the one factor. The second factor is the polypharmacotherapy. Pharmacotherapy in acute care setting is quite complex, especially with elderly population, because most of the time they have many diseases that they are receiving many treatments for it. The issues with pharmacotherapy include, first of all, the polypharmacy. You have multiple medications and multiple prescribing providers. They have their PCP, they have their cardiologist, they have their gastroenterologist, and each one prescribing different medications and most of the time they don't communicate with each other. So that can cause an issue. When they are hospitalized, sometimes in the hospital, their medication comes in a specific formulas. So medication reconciliation should be taken very seriously, because if you're going to change the formula, you don't use specific medication because you don't have it in a specific formula. There is a lot of barriers for medication reconciliation itself, which it's an issue in itself, because sometimes they come in, they don't know the name of their medications, they have cognitive impairment, they don't have someone to help them with their medication. It's not easy to contact their PCP or pharmacy to provide you with their medications at any time of the day. There is significant turnover of the medication regimen, with many old medication discontinued and new ones introduced. One of the things that can happen with suboptimal polypharmacy is adverse drug event. They are a significant source of hospital hazards for older patients. Patients at risk of developing adverse drug events can be identified using an index that includes the number of drugs, history of adverse drug events, if they have heart failure, liver disease, and renal failure, and if they have more than 4 conditions. So if you have a patient that has multiple drugs, or they told you that they had an adverse drug event priorly, or they have heart disease or renal failure, or they have more than 4 conditions, you have to be very careful with medication reconciliation. And you have to look at what they're taking and assess it, even if they've been taking it for a long time. There is two criteria that they're used with elderly patients for reducing inappropriate prescription. It's the BEER criteria and the STOP criteria, which is a screening tool for older persons potentially inappropriate prescriptions. I will attach a link for both of them if you want to look into them further. So what? So when you admit the patient, and at discharge, when you're discharging the patient, and during hospitalization, if you add any new medication, these are the times for reviewing the patient's medication. So when you want to make sure that you have all the medication that they're taking, if you added any medication or any treatment, you want to make sure that there is no adverse, there is no contraindications or medication that interact with each other. And at discharge, when you discharge them, you have to make sure that the medication that they're taking with them are appropriate. The thing that you would do when you review their medications is you either discontinue or change the medication that are unnecessary or duplicative. If they have low therapeutic value, like sedative and hypnotics, or they are prescribed the wrong dose or the wrong frequency, they interact with each other or with other conditions, or they are prescribed despite a known allergy.
We just lost Amna, but she did a great job, so we will wait for her to finish I think she has a couple of slides, if I'm not mistaken. Excellent presentation. So at the hospital, I think when you join residency, you find out that a lot of complications that happens to all the patients in the hospital, as just mentioned in the slides. We just reviewed this Eiman. Any questions or any addition, any comments from the group as your experience as far as our hospitals, our places? Anyone wants to share? If not, then maybe we can switch to the next topic.
Okay, the next topic is publishing articles at Cureus. Will be presented by Dr. Ammy and by me.
Sounds good.
But Ammy, you can start now.
Hi, everyone. Hello, Dr. Nadir. So, can you see my screen?
Yes.
Yes, you can see.
Okay. Okay, so here we are discussing today the publishing with Cureus. So, okay, let's start. So, acceptance policy and the editing fees of the Cureus. So, Cureus is a wonderful way to publish our articles, and Cureus is committed to providing easy, timely, and affordable article publication. They expect all submissions to adhere to our rigorous formatting and the language requirements, placing this responsibility on the author via DIY submission process allows many authors to publish with zero editing fees. Preliminary acceptance occurs when the article enters the peer review, but comprehensive editorial review and the assurance of the publication will not occur until the article is submitted for the publication after the peer review. So articles that exceed our author or reference limits or contain too many formatting or language errors are identified during the preliminary review that will require editing fee. However, Cureus does not charge article publication fee. So they only charge for the editing fee, but there was no publication fee. So what they require is a credible peer review, which means Cureus publishes all credible medical science applicable to the global healthcare community. Article credibility is determined by favorable commentary from trusted peer reviewers that includes substantial critical feedback confirming the absence of fatal scientific or methodological flaws. Please note that medical students are not allowed to be a peer reviewer. Positive reviews that lacks in substantial constructive feedback will also be scrutinized by the editors of the Cureus and may be rejected. So while authors are required to suggest for 5 peer reviewers, at least 2 completed reviews from Cureus invited reviewers are required in order to satisfy the peer review. Okay, so the academic fraud policy. Cureus does not tolerate plagiarism, data or figure manipulation, knowingly providing incorrect information, copyright infringement, inaccurate author attribution, attempts to inappropriately manipulate the peer review process, failure to discuss or failure to declare the conflicts of interest, and also fraud and libel. Cureus pledges to vigorously pursue and investigate any offending parties to ensure that their transgressions are recognized by their employer, institute, and relevant governing body. So what do we need to qualify our article for a free publication? So in order to remain eligible for the free publication, articles cannot contain more than the following number of authors or references. Exceeding either total will disqualify the article from free publication, regardless of how many errors are found during the preliminary review. So the original articles should have 10 authors and 30 references. Case report or technical report should have 5 authors and 20 references. And editorials should have 5 authors and 5 references. All non-channel or competition review articles submitted to Cureus will be required to purchase their preferred editing service in order to proceed with peer review and publication. Only well-drafted, relevant, credible submissions with few or no errors will be permitted to the publication for free. Articles with too many errors will be required to purchase the preferred editing service, and articles with severe language issues will require professional language editing by the third party in order to be considered for the peer review and free publication. DIY editing service like Grammarly will not be accepted. So what are the kind of articles they accept? So the Cureus accepts and publishes 5 different articles: original articles, review article, case reports, technical reports, and editorial reports. To be considered for publication, each article's type must include the sections listed below. Only original articles may include abstract subheadings. So Cureus does not accept or publish article commentaries or letter to the editor. So original articles, case reports, technical reports, or editorials that exceed the specified number of authors or references will no longer be eligible for the free publication. Review articles do require to purchase the preferred editing regardless of the number of authors or references. So let's see what are the type of the articles. So original article. Original articles are the report of an original research that are classified as primary literature. This is the most common type of journal manuscript used to publish full reports of data from research. Original articles may also be referred to as research article, research, or just article, as this format is suitable for many different fields and many different studies. Whereas case series with 6 or more cases are considered retrospective studies and must be submitted as an original article, with a far more extensive study than a typical case report. Then comes review article. So review article give an overview of existing literature in a field, often identifying the specific problems or issues and providing a balanced analysis derived from an available published work on the topic. Review articles can be one of 2 types. So broadly speaking, it can be literature reviews or systematic reviews. Bibliometric analysis and meta-analysis articles should also be submitted as a review article. And Cureus does not accept any kind of mini or brief reviews. Then comes case report. Case reports present the details of real patient cases from medical or clinical practice. Cases may contribute significantly to the existing knowledge of the field or showcase less novel results. The report is expected to discuss the sign, symptom, diagnosis, and treatment of a disease. A goal of case report is to make other researchers aware of the possibility that a specific phenomena might occur. Case series of 5 cases or fewer must be submitted as a case report. Any MRI, CT, X-ray, scan, image which is mentioned in the case report must be included in the article unless it shows nothing of interest. Articles featuring both a case presentation and literature review must be submitted as a case report. Autobiographical case report must include a physician as author or co-author. So this is about case report. Then comes technical report. Technical report, or which is also known as scientific report, is a document that describes the process, the progress, or the results of technical or scientific research, or the state of a technical or scientific research problem. It might also include recommendations and conclusions of research. Topics which are not accepted in the Cureus are surveys of medical students or residents, like the articles surveying for medical students or residents will be rejected. Then articles which are related to resident student burnout, stress, anxiety. These are also rejected, and every kind of mini reviews are rejected. So I had this much. I think Alma will continue.
Thank you, Ammy, great presentation. But before I continue, I would like to ask a question. What is meant by survey of medical student or resident? Like us, for example, we cannot publish on the website for the donor. Maybe Dr. Nader.
No,
I think when
they,
this says, yeah.
go ahead, Amy, go ahead. Amy, go ahead.
Yeah, so my understanding was if a medical student can be a part of an article, but if they do any kind of survey, that cannot be published in the Cureus.
I do agree. Yeah. So sometimes the medical student may distribute some surveys about less difficulties, step one, or residents. They send a questionnaire about burnout or whatever they go through in residency. So all this information may be used for quality improvement or doing other stuff in the medical school or in residency. So they don't accept them as projects for publication at Cureus. So for you guys, if you want to do a study, you can do, I think some of you already published some studies like reviews with Cureus. So you can submit some work done as articles, review articles or other studies like case report if you want to, and then they will accept from you. But if you want to do only, let's say we want to do a questionnaire about this fellowship and how to improve it, it's not going to be acceptable.
Okay, I understand. Thank you. Okay, everyone, I will present a short presentation about the publication process and submission at Cureus. Are you able to see my presentation?
Yes.
Okay. Usually the publication process takes about 4 weeks of submission, and it must be through online system, not accepted, for example, to email. And the process encounters several steps. First thing, you have to enter all the article information, for example, the co-author's name and their affiliation and the text. And you have to disclose any relevant conflict of interest and adhere to any relevant ethics statement. And to enter contact information for at least 5 potential reviewers for peer review step. Then you submit the article for editor check. A preliminary review by the Cureus editorial team. First, they check the articles, and according to this, it will be directed through one of the following pathways. Either be approved for peer review if there is no editing is required for the articles. And if there is multiple formatting or language errors, it will be shifted to preferred editing service. And if severe language issues are present, they should be third-party service for editing the articles. Or the article will be deferred for revisions by the authors. For example, if there is scientific wrong information or things that can be edited by the author itself, it will be deferred to be revised by the primary author. And it also can be disk rejected because, for example, it is not beyond the scope of the journal. Like, for example, what Emmy said, I think of studies on medical students or residents. Either also the last thing, that the article will be blocked. The author will be blocked from submission again in Cureus if they, for example, there is fraud, academic fraud or anything that violates the policy. After the editing finished, the articles will go to preliminary acceptance. This is approved by for peer review. Invitations are emailed to the author suggested reviewer, as well as 6 reviewers automatically invited by Cureus. So typically the reviewers are 2 types. Half of them invited by the author itself, and the rest will be invited by Cureus. After if each reviewer comment and say their suggestion, then the article will be unlocked for editing, so the author can edit what is suggested for him. Then the article will be submitted for editor approval. An associate editor will conduct final editorial review to confirm the article's suitability for publication. This includes ensuring that all reviewer comments have been acknowledged and addressed appropriately. Then the copy editing, the article is approved for publication when a copy editing has been completed and the author is notified that they can now sign in and publish the article from their dashboard. This is when all the editing has finished already. Usually there are many types of authors. The submitting authors who are the one that in charge for editing the articles and writing the author names and their affiliations. And all Cureus email notifications sent during the submission process will be sent to the submitting author. The corresponding authors does not have the edit access. And all the submissions must include a senior author, like for example, MD, or DO, PhD, PhD, MB, BA. So I think it's not suitable that all the authors are medical students, for example, they must be senior author. Submitting articles. When submitting articles, the title, do not enter the title in all caps or include a period at the end. For example, initialism abbreviations are not permitted in the article title, exception for the common abbreviations such as COVID-19, HIV, MRI, and should be only 1 sentence. The abstract should be about 3,500 characters limit. The keyword used are 5 to 10 keywords. The submitting author usually add the co-authors. Authors cannot be added after submission, so make sure to include all authors prior to submitting. Submitting author is listed as the first author by default. You are responsible for editing all author names and affiliation. Make sure that you write the correct name and affiliation. Disclosure. Please provide all relevant information pertaining to any human or animal subjects and disclose any relevant conflict of interest. You may also add acknowledgement at this time. In the event that human or animal subjects are included in the articles, please provide the relevant IRB names and approval numbers and confirm that informed consent was obtained or waived. Then you enter the main article content. If you previously presented your articles as an abstract or poster, this must be mentioned in the introduction. And also include the meeting or conference title and date. The formatting of the text, there should be no paragraph indentation or bold list. Only 1 line written after each paragraph and only 1 space between sentences. Please remove any text styling before copying and pasting your text into the appropriate field. The conclusion should contain 1 to 2 paragraphs. And the numbers in the articles should be spelled out except in case of measurement. from 1 to 9 should be written, but written as spelled out, unless in measurement, you can write just a number. Numbers higher than 9 should be internumeric. Media is not permitted in the abstract, introduction, or conclusion section of any article type. The only exception is the introduction section of a review articles. And each article is permitted up to 25 media items. To add media to your articles, first place your cursor in the desired location in the article section text and click one of the insert figure, insert table, or insert video buttons on the article section toolbar. You will then be prompted to upload the figure or paste the table or the video URL and add the title and optional link. Republished figure must include a proper attribution and include a note that permission was obtained from original publisher. Both attribution and permission should be included in the figure link. All tables must be cell-based, images are not accepted. Regarding references, it should be cited using square braces. All material included in the reference list must have been previously published in citable journal or books. And the Cureus usually requires the DOI numbers to be included in all references when it's available. Number references in the order in which they mentioned in the text. And after entering the references, it goes through automated converting tool, then review the references and edit if required. The reviewers, there are two types of reviewers, author invited or Cureus invited. The author invited are usually minimum of 5 individuals with suitable domain knowledge in the field of study, and Cureus invited reviewers minimum of 6 peer reviewers. If there are 2 completed reviews from Cureus invited reviewer are required and to satisfy the peer review. The summary contains a section by section outline of your articles. You can review each aspect of your articles and jump directly to a specific section of the submission process if you would like to make changes. Please preview your article drafts one last time and make sure that everything looks good. You cannot submit your draft without first previewing your work. When you are satisfied, click the Submit My Article button. This is all. Thank you, guys. And for more information, you can visit the website. Thank you.
Thank you so much, Anna and Amy. Thanks. This is great. Thank you so much. Concise and to the point. So, and I think we already have submitted 2 articles, and both of them were accepted as Cureus. So, great. Any questions? Any addition? Any comments from the fellows? Please raise your hand or jump at your comment or questions.
So, Dr. Noor, I have a question.
Yes.
Yeah. So, I have heard and some of my colleagues, they mentioned that Cureus is not a well-reputed journal because the process of review in the Cureus is very ambiguous and very vague, and like a lot of dubious or fake publications, fake articles have been published into Cureus, and they retracted some of the articles from Cureus. So what if we submit papers into Cureus, so is it going to help us in the residency application, or they're going to look down upon to have a publication in Cureus?
So it's hard to say, but it's a way of depending on what you wrote in that article. If it's an important topic and they accepted it, I think it will help you. And you can talk about your results or your article during the interview. If it's not a good article and they publish it for just money or something, then maybe they will look at that down. But there are some journals that they are not good as far as the reputation. But I think they are improving. The Cureus model, I think it's improving. And I think it will, down the road, will be recognized as a good option, especially with the way they do the review. And yes.
All right. Thank you so much. Thank you so much.
You're welcome. Thank you. Anyone else?
Yeah. So the last thing, how to start a YouTube channel.
Yes, go ahead.
Okay. So can you please see my screen?
Yes.
Yes.
Okay. So today my topic is how to start a YouTube channel. As we know that, I'm just a minute. As we know that social media has become a widely used media for the dissemination of information, and such as Facebook, Twitter, Reddit, and also YouTube. They are being used for the various purposes such as entertainment, education, learning, art, science, technology, and also the education of medicine. So YouTube has become a very widely used tool for the dissemination of information and education, and it has become the biggest website for the videos, and you can find videos in each and every language on this website, and on almost every topic. So this is really an important and significant tool which we can use to spread knowledge, information, and also build up our profile. So now we're going to understand that how we can start a YouTube channel from scratch. So first of all, we need to identify what is our target audience. And for example, if a person is going to make YouTube videos about the presentation or about creating awareness for common health related problems such as hypertension, diabetes mellitus, and certain malignancies. So the general population is targeted in this case. And on the other hand, if we're making videos for, say, we are creating videos for USMLE topic for teaching medicine. So it means our target population is the students which are studying the USMLE, which are prepping for the USMLE. So it is really important to understand the needs, requirements, and the taste of the target audience so that we can tailor our videos, our content as per their needs. So it is going to help us, and it is also going to help them, the people for which we're creating the videos. So first process we talked about that we have to decide what is the target audience, and then we have to decide what are the necessary skills and tools which are required to channel. Obviously, there are some physical tools such as you must need to have a camera or and a laptop and a mic. You can create a YouTube video using a mobile phone or using a laptop, a webcam options. And then also you need to build up some verbal communication skill in order to manifest, in order to express your views in a clear and elaborative manner. So equipment required, like we can say that anything in which can be used to film videos, like camera. You can use a mobile camera, or you can use a laptop camera. You can use a webcam. Anything which is available, you can start with it. And then as your channel grows, you can upgrade. Your equipment set. And the number two thing, to record an audio, such as a mic, unique a mic, or in order to have a crisp sound, and in order to avoid the distraction from the background. And obviously, you need to have a certain skill set to edit the video. For example, when we are recording a video, there is some we are retaking, and we need to remove those clips which are unnecessary, or in which we performed the repetition of the recording of the video. So we need to take them out. So we need to remove them. So, and sometime we need to add something into video. We need to add subtitles. We need to add some text. We need to add some image. For this purpose, we need to edit the video. And for this purpose, we can use a video editor. In Windows 10, we have a simple video editor in the Windows 10 provided by the Microsoft. And also there are some professional softwares available for the pro level of the editing, such as Adobe Pro and Shortcut, etc. And we can watch, like as I mentioned, that there are YouTube videos available on the YouTube for video editing and for everything, for each and every topic. So we can watch videos for understanding and learning the video editing process. So the next thing is to activate your channel. And to activate your channel, all you need is a Gmail ID. All we must be having a Gmail account. And what we have to do, we just have to log in into YouTube using a Gmail account. And then we can it would be better if I share my screen and I perform it. So it would be better. So I'm going to share my screen. So you can see that here is YouTube and on my desktop, and you can see that I'm going to log in from scratch from the very beginning. I'm sorry for the poor connectivity, but yeah. So you can log in into YouTube, and then there is a sign, and in which you can create the videos. And before this, we can see that we can a banner which basically gives information about the content you are producing. For example, this is a banner in front of me, and the name of the channel is Med Coffee, a platform where you can relax and study with a cup of coffee. Like this is just a hypothetical thing to and then like this is a banner, and you can create this banner using the Canva. Canva is a software which can be used to create a YouTube banner, and there are a lot of templates available on the Canva, and you can use those templates, and you can as per your needs, and you can upload that particular banner onto your YouTube channel. And then, for example, if you want to upload a video, suppose you have created a video and then you want to upload it onto YouTube. So you have to click onto this on this sign, and then you can click on the upload a YouTube video, and then it is going to take you to the next windows in which you have to uh, upload the video. So it is just taking some time. So yeah, so now we have to select a file. So I'm going to select a file, and so here is a video. For example, I select a video from my desktop, and I just randomly selected a video, and now the video is being selected, and it is here. And now I have to add a title here. Title is required, and the title should be very brief, concise, interesting to grab the attention of that video, description about your video. For example, you have to describe that this video is about hypertension. I have talked about hypertension in this video, how the hypertension affects body, and what are the complications of hypertension, and so on. You should briefly describe the content of the video in this section, and then you can add some tags here. And then thumbnail is basically an image which basically attracts the attention of the viewer. For example, the very first image which appears on the YouTube is known as a thumbnail. So it is basically built in order to attract the attention of the viewer. So what you are going to do, you are going to create thumbnail using, again, there are a lot of options available how to create thumbnails. Like you can thumbnails using Canva, you can in the Microsoft Windows, and you can build a thumbnail as per your needs, and then you can upload that thumbnail using this button. So for example, there is a file, and I'll just upload that file, and for example, thumbnail, and then I can add this into a playlist. For example, I can add this into surgery playlist. I can add it to neurosurgery. Like you can develop your playlist as per your needs, and then you can add your video into a particular playlist, and it would help the viewers, and it will also help you to organize your content into playlist and into categories. And then you're going to click the next, and then in which the YouTube will ask about this video is either this video is about kids or it is not related to kids. This video is not about kids. So I just clicked on no, it is not made for kids, and I'm going to the next windows. And you can see that I add subtitles here, and I can add some cards here, and then YouTube is going to check the copyright, right? We cannot upload, as per the policies of the YouTube, we cannot upload the videos created by someone else because of the copyright issue. So we need to upload a very genuine and the video which is created by us and not by someone else, because otherwise YouTube will ban you, and you will have to remove that video. And then we're going to YouTube perform a check, and then after the initial check, you can proceed to the next. And then here is the next pop-up in which there is save or publish. We can use it. We can set it as private, unlisted, or public. So you can leave this video here. Unlisted means only the person who have the link, you share the link with them, they will be able to watch the video. The other person will not be able to watch the video. This is the unlisted YouTube video. And the private is like, it is just visible to you. No one would be able to see this video. You just able to watch this video. So we're going to select any option as per our requirement, or we can schedule the upload of the video. For example, I want to schedule this video to upload on November 14th at this time, and then time zone, and I can also and then can schedule it for publication, and then that video will be published on that particular time. About a description about how to start a YouTube channel. It is really a very comprehensive and technical aspect, and I just tried my best to summarize and describe the pertinent information in a very concise manner. If you have any question, please you can ask me. Hello. Can you hear me?
Hello, yes.
Thank you so
Yeah, we
much
can
for.
hear you.
Yes, we can. Thank you so much.
So if you have any question, you can ask me.
Thanks. This
If
is
you have
great
any
and great.
question,
Yeah, this is great explanation.
thank you so
much. Thank you so much.
much.
Yeah, please feel free to ask Usman if you have questions. So,
Dr.
no
Nadir,
more questions. Go ahead.
so wanted to ask you that we're working a project related to COVID-19 and YouTube as an educational tool for raising awareness about COVID-19 pandemic in the elderly population. And because of the mesh process and the members were busy in the application, it was delayed, but now we have finished and we have completed it. And like we wanted it to submit in the conference which you shared a few days ago.
Sounds good. So you can create the abstract and then you can submit it to either the AMDA. I think it's in a few days, or at the end of the month there is another conference AGS, the American Geriatric Society. So we have options. So
All right.
if you are done, share with me the abstract and distribute quickly, and then if everything is good, you can go ahead. Amna is free. AGS, you have to look at the website and see how much.
All right. Thank you so much, Dr. Nadir. Thank you so
You're
much.
welcome. Thank you. Good job. Excellent.
Next topic is a mock interview with Dr. Muarib, but she apologized. She had emergency. She could not attend. So if anyone want to volunteer for interview,
That's fine. You can just jump in and see. I know some of you might have some interviews coming, so
yes.
it's a good option. So, fine.
Actually, the next thing is project update.
Okay. So Dr. Usman mentioned about the YouTube project. Any other projects that you guys are working on? You want to update? I know we have an abstract that will be submitted or will be presented next week in Arizona, I think, in person. So the team already finished the first step. So anything else from other groups or other project leaders? Or maybe any other questions about any ideas or projects that we are going on doing? If no comments or questions, that's fine. So maybe we can talk about next meeting agenda. If you have any suggestions, please let me know. So I can just share the agenda for next week. So I think the red team, either Hattie or Dina or Mary, or maybe someone from the team might step up for the meeting. We'll talk about the syndrome in general, Dirac syndromes, and maybe we can talk about other topics like the graph that we use in some of the articles, and maybe some of you would like to do some interviews again, and we can talk about that. If you have any suggestions for other topics, please let me know. Anyone had interviews or interview in the past few days, weeks that you can share with us? Or if you have plans for interviews in the coming days, weeks, you already invited. Want to share?
Hi, it's me, Ravda. I have a coming interview. I didn't have interview yet.
Sounds good. Congratulations. Internal medicine or family or something else?
Actually, I have both. I have for White River Health, Arkansas for internal medicine, the Brooklyn Hospital Center for family medicine.
Excellent. Good. Are you ready for the interviews?
Honestly, the practicing make me sound like a robot, so I don't know what to do. Like when I practice, the answers sound so robotic and like I'm just, I don't know. I don't know. So I stopped practicing, to be honest.
That's fine. So my advice is just to take it easy during the interview and treat it as a conversation. So as much as they want to get information from you, try to share your information and try to get information from them. See if that program is fit for you as well. So it's an assessment kind of.
Okay,
approach.
thank you.
You're welcome. Thanks for sharing. Anyone else?
Yes, I have one in the upcoming, in the next 2 days.
Excellent. Good luck. How's the
Thank you.
preparation?
It's all right. I'm preparing with this group. It's called Resi. I'm sure everyone here also has joined. It's a good. They have like everyday mock interviews, and it's
Perfect.
really helpful. Yeah.
Excellent. Excellent. Sounds good. Okay. Any feedback from that group that you want to share that you think might improve or help the residents and the fellows in this group? Or anyone else can share? I wish you all the best. So I'm welcome the rest. That's good.
I didn't hear what you said, Dr. Hadi, sorry.
I said I wish you all the best, both of you. Thanks for sharing.
Thank you, Dr. Naida.
Thank you.
Thank you,
Anybody
Dr.
else?
Naida.
You're
Yeah,
welcome so much.
I had a meet and greet with one of the interviews.
Excellent.
Yeah, I think preparing at least 10 questions for residents and for faculty, because sometimes the answers are already mentioned during the initial presentation, and at the end you're stuck with repeat questions. So have a list.
Yeah, I agree. I think if you have 10 questions, that would be great. And as I mentioned to Robert, you want to learn about the program. So if you have anything that's unclear for you, let's say you like the program, but you don't want to go there and find out, if you can make sure everything matches your needs. Excellent. Thanks for sharing so much.
I have a
Go ahead.
question, Dr. Nader. If in
Okay,
the
go.
interview they asked me like, if, as you said, if they covered everything during the interview, like everything about the program, and I end up having no question for them, is it okay to tell them like, can you please give me an advice or whatever? Like, I know that you're experienced and I would love to hear and to get an advice from you. Is that okay to ask them this question?
Yes. Actually, some of the fellows in the past, they asked the same question or similar during the interview after the event. And you can talk about anything, actually. You don't have to stick yourself to one topic. It depends on their availability. If they appear as they are in a hurry, they want to finish this, go to the next, then you don't have to mention or share some. But in general, you want to ask about their experiences. One question will be like, how did you do with COVID? How did you handle it? How is your personal experience? Something on a personal level you want to share. And then at the end you can come up with, and how do you feel about, if you want to give me an advice about my performance today or the interview today, or if I can improve or some suggestion. So you can put it in a different way. But that's a good option. Thank you. Bashir, go ahead.
I guess Bashir raised her hand.
Hi, Dr. Nader. Hi, everyone. I just wanted to update you, Dr. Nader, regarding our research project, meta-analysis of thromboembolic disease. Actually, we're done with writing the manuscript, and I'm going to send to you in your email. We would appreciate feedback.
Sounds good. I will look forward to that. Thank you.
Thank
All right. Any other comments or questions? Anything else you want to share? If no, then maybe we will see you next week. Hopefully, I hear good news from everyone. I wish you all the best, and I'm doing great. Thank you for the presenters for today, and I wish Victoria or Toa did not make it, but I wish all the best for you guys and for the presenters. Thank you for thank you for moderating the meeting. We'll see you next week. Assalamu alaikum.
Thank you.
Thank you, Dr. Nader.
Walaikum assalam. Thank you, Dr. Nader, so much. Bye.
Thank you.
Thank you, Dr. Nader.
Thank you
You're
so
welcome.
much.
Thank you very much. Bye-bye.
Thank you so much. Assalamu alaikum.
You're welcome. Assalamu alaikum.
Thank you, Dr. Nader. Thank you so much.
Thank you, Hassan. You're welcome. Thank you.
Thank you, Dr. Nader.